I know we have folks that are still being connected to the Zoom. I will go ahead and get started with introductions. We have a lot to cover today. And I am sure that we will have questions that come through. So I will get started, and please keep your eye on the chat. I will help communicate with those of you with questions within the chat. And as usual, we'll take time towards the end for any direct questions. If something is timely, I will go ahead and interrupt the presentation for a brief question. Keep in mind, everyone, this is a very intense topic, and we have had a lot of incoming requests and for clarification and updates specific to this this rule. And so Rochelle thought it would be a really good idea for us to do something specific to this, and I agree. So we'll go ahead and get started. Let me pull up my document. Okay, everybody. Well, as usual, thank you for joining us today. I am Molly Brown with the Heartland Telehealth Resource Center. And today we're going to be continuing our education series focused on telehealth, billing, coding, and policy. A few things, I'm sure you guys hear it every time, but for our new folks that are joining today, the session is being recorded and we'll share it with you afterwards. Your microphones have been muted, so please unmute if you'd like to ask a question. I will ask during this specific webinar if maybe you use the chat simply because we do have a lot to cover, and I'll help monitor that. It might be a little bit easier for us to navigate some of the Q&A that'll come through. Your completion certificates will be emailed, and it's important to sign on with your first and last name so we can identify you. You can rename yourself by using those 3 dots in the upper right corner of your Zoom profile. So let's get started. Today we have Rochelle Martin. She is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're very pleased to have her today because, again, this is a very important topic that requires her input and some navigation through some of this information. So we're going to be talking about the in-person requirements or the 6-month rule for mental telehealth visits. So now I will turn it over to Rochelle to get started.
All right, thanks, Molly. So the reason Molly and I sort of coordinated to have this session today is, of all of the telehealth rules, flexibilities, policies that have come out in the last couple of years, this one that you hear as the 6-month in-person visit requirement is probably the one very single narrow topic that we get the most questions on. So I thought it would be good and important to talk about what the 6-month in-person visit requirement is, when it applies, and almost as importantly, when it doesn't apply. So to do that, I kind of have to walk through a couple of stages in our evolution of telehealth coding rules. So I'm going to talk about the basic, what I'm going to call the regular Medicare telehealth rules. And the reason I want to talk about those again is because this in-person visit requirement does not apply if a service would already be covered under the regular Medicare telehealth rules. So we're going to really try to drive those home and keep in mind what those regular rules are. If a service fits within those parameters, we don't have to worry about the 6-month in-person visit requirement. So then we're going to talk about something that happened even before COVID on a permanent basis, called the Support Act. And the Support Act, because I realize I've got the names of the laws on this slide, but I realize we don't think in terms of acts and the names of the laws. So the Support Act, I'm going to call the substance use disorder telehealth rule that expanded. It added on to what is available under regular Medicare telehealth rules to add some options, some accessibility, and some other ways that telehealth specific to different substance use disorders could be available and payable. Then we had, just a year or so after that, something called the Consolidated Appropriations Act of 2021. Nobody thinks in terms of the name of the act. So what I'm going to call that is the 6-month in-person billing requirement. That's where it came from. That's the law that created this in-person visit requirement that we've seen and heard so much about. We're in the middle of the COVID public health emergency. So we know we've got some flexibilities now until the PHE ends. And then just earlier this year, a different law was passed. We don't think of it in terms of the name of the act. So what I'll call the Consolidated Appropriations Act of 2022, I'll call that the 151-day extension. And what that did was extend some of the rules that we have available during the PHE to make them available for at least 151 days after the end of the public health emergency. And the reason I say at least is because we're hoping that gives Congress enough time to make some permanent changes to rules through some of the bills that are already out there, including some that would eliminate this 6-month in-person visit requirement altogether. So once we kind of walk through those different rules and what they do, what they require, what they don't require, when they apply, when they don't apply, we'll walk through some specific examples of different telehealth scenarios and talk about whether the 6-month in-person visit requirement would apply or not. So this kind of pyramid, it's got the names of the different laws that we're talking about, but really what I want to emphasize is those at the bottom, the regular Medicare telehealth rules. That is the foundation. That's the baseline coverage. These rules that have come about after that, they are adding to what is already available. Okay, and again, I know we're not thinking of these in terms of the names of the acts, so I'm going to give them nicknames for purposes of this afternoon. And the regular Medicare telehealth rules is sort of our baseline. That comes from a combination of rules in the Social Security Act. And when it comes from the Social Security Act, that means the only way that they can be changed is through a law passed by Congress. Some of the regular telehealth rules under Medicare come from agency interpretations. So those are things that Health and Human Services or Medicare could potentially change through rulemaking rather than requiring Congress to pass a law. So we'll talk about that a little bit. We know that we've got some things that have opened up as a result of the public health emergency, things that the agency has the authority to create these flexibilities, but only until the public health emergency ends. Things like allowing telehealth services to be provided to patients at home, that's not normally available outside of the public health emergency, and it's not something that the agency can do outside of the public health emergency. That's set by statute under the Social Security Act, under the regular Medicare rules. And so this law that was passed earlier this year by Congress says some of these flexibilities that the agency has created temporarily through their authority as a result of the emergency, they will stay in effect by law for 151 days after the public health emergency ends. Then building on top of that are the Support Act, what I call the Substance Use Disorder Telehealth Rules, and a subsequent law creating the in-person visit requirement. So let me talk about the regular Medicare telehealth rules, because I want to emphasize throughout our session today that if a telehealth service, whether it involves a typical medical condition like hypertension or diabetes or substance use disorder or a mental health condition that co-occurs with a substance use disorder, or a mental or behavioral health condition that doesn't co-occur with substance use disorder. Regardless of the diagnosis, if the telehealth service for a Medicare individual fits into these the 6-month in-person visit requirement does not apply. Not now and not after the PHE ends, not after the 151-day extension. So anytime the telehealth service fits into these parameters and is covered under normal rules, we don't have to have an in-person visit within 6 months of the first telehealth visit. So those parameters are that the patient, the place where the patient is located, called the originating site, under normal rules, has to be in a rural geographic area. And there's a very particular definition of what a rural geographic area is, but for purposes of today, we'll say a rural geographic area. And within that rural geographic area, at the time that the telehealth service is rendered, the patient has to be at an eligible originating site. So that could be a physician office, an FQHC, an RHC, a critical access hospital. You see the list of those there. Now, that very last one, home, is only available for extremely limited purposes outside of some of these increased flexibilities, and really doesn't impact the topics that we're talking about today. So rural geographic area, within the rural geographic area, the patient is at an eligible originating healthcare site when the telehealth service is rendered. The provider at the distant site who's rendering the telehealth service has to be one that is eligible to deliver a telehealth service. So eligible distant site providers are physicians, nurse practitioners. Under the statute, distant site providers does not include speech therapy, occupational therapy, what am I missing? Speech, physical therapy, speech therapy, occupational therapy. It doesn't include FQHCs or RHCs or critical access hospitals by default, okay, outside of our COVID flexibilities. The telehealth service has to be rendered using a telecommunication technology. Now, under the statute, Congress did not define telecommunication technology. But the agency, Health and Human Services and Medicare, have defined through rulemaking that telecommunication technology means live, two-way audio and visual communication by default, right? Not outside of the COVID public health emergency. And then the service that's being provided, the code that you would assign for that telehealth service from the distant site professional, has to be one that's on the approved telehealth list. When all of those requirements are met, even after the PHE ends, even after the 151-day extension, you would not have to have an in-person visit within 6 months of the initial telehealth visit. Even if that telehealth visit is for mental or behavioral health conditions or substance use disorder, or conditions that co-occur with substance use disorder, okay? So with that sort of foundation on the regular Medicare telehealth rules, remember that's the baseline, and these other rules are adding to or expanding the access of telehealth from that baseline. One of the challenging things about our COVID flexibilities that we've got right now is that some of them that won't continue when the PHE and some of the extensions after the PHE end is that what they're doing now during the public health emergency is filling in or making available services that we couldn't provide as telehealth prior to March of 2020, but it's saying they can be covered under this bottom point to the pyramid, but at a baseline as a regular telehealth service. So things like allowing certain visits to be rendered to patients at home via telehealth, certain services to be rendered with audio only telecommunications technology. Even though those weren't available before the PHE, right now, those are covered as regular Medicare telehealth services. And we don't have to rely on these extensions, these flexibilities yet. At the time that those flexibilities are no longer available, that's when we'll really have to look to the top of the pyramid, or the top of this inverted pyramid here, to be able to continue to render some of those mental behavioral telehealth services via audio only, or to patients at home, because only at that time will they no longer be covered as regular Medicare telehealth services. So March of this year, well, let me back up. Those flexibilities that we have during the COVID public health emergency, including making the home an eligible originating site, even outside of rural geographic areas. That's something we can do as long as the public health emergency continues. Then in March of this year, what's called the Consolidated Appropriations Act of 2022, what I'm going to call the 151-day extension, was passed. And it said that flexibility to be able to provide telehealth to patients at home, regardless of whether they're in a rural geographic location, that will continue by law for 151 days after the public health emergency ends. And the ability to render telehealth services that are eligible to be provided as audio only now during the public health emergency will also continue for 151 days after the public health emergency ends. What that means is that for a period of throughout the rest of the PHE, and for a period of 151 days after the public health emergency ends, we can continue to deliver telehealth services to patients at home. We can continue to use audio only if the particular telehealth service is permitted as audio only, and that will continue to be considered a regular Medicare telehealth service, meaning for that 151 days after the PHE ends, we don't have to rely on the Support Act or the Consolidated Appropriations Act to make those telehealth services available. That means the 6-month in-person visit will not apply until that 151-day period ends, and then only in certain circumstances. So let's look at the Support Act. The Support Act I think it was in 2019 when the Support Act was passed. And it built on those services that are covered under the regular Medicare program. See if I can get my highlighter here. Right, so under the regular Medicare rules, the patient has to be in a rural geographic area and at an eligible originating site when the telehealth service is rendered. And under regular Medicare telehealth rules, that doesn't include the patient's home. And so the Support Act, even before COVID came about, on a permanent basis, allows us to render a telehealth service to a patient at home when the telehealth service is for the evaluation, the diagnosis, or the treatment of a substance use disorder, or for any mental or behavioral condition that co-occurs with a substance use disorder. So before our flexibilities from COVID came about, we had this expanded ability to render telehealth to patients at home for those diagnoses that weren't available under the regular Medicare telehealth rules. That's permanent. So even after the 151-day extension, whenever the public health emergency ends, whenever we revert back to regular Medicare telehealth rules, we can continue to provide mental or behavioral telehealth services to patients at home for substance use disorder or mental behavioral conditions that co-occur with substance use disorder. And the in-person visit within 6 months does not apply to those services. So one of the keys from a coding and billing perspective, once 151 days after the public health emergency ends, will be when you are rendering these telehealth services to patients at home for substance use disorder or conditions that co-occur with substance use disorder, is to make sure in the diagnosis fields on your claim that you're always including the diagnosis code that reflects the substance use disorder for that service. That's how we know it falls under the Support Act. That's how we know an in-person visit within 6 months of the first telehealth visit for substance use disorder or conditions that co-occur with substance use disorder, that 6-month in-person visit doesn't apply. But remember, even if we are evaluating, diagnosing, or treating substance use disorder via telehealth, or mental and behavioral conditions that co-occur with substance use disorder via telehealth, if that telehealth service meets regular Medicare telehealth rules, then we don't have to rely on any flexibilities and coverage through the Support Act, which means that we can continue to do that for patients in rural geographic areas, patients at eligible originating sites. That doesn't change. The only thing that changes with the Support Act is it lets us provide those services to patients at home, and a 6-month in-person visit does not apply. So now the consolidated. Yes.
I'm sorry, I unmuted and muted myself again. So we do have a quick comment in the chat box, some information that came from the Center for Connected Health Policy. And if you wanted to comment on this, it might be helpful. If the existing PHE designation is renewed one more time until October 13, the additional 151-day extension will further continue most policies until March 13, 2023.
That's right. I don't know the exact dates, but that's right. And we expect the public health emergency to be renewed in July for another 90 days. The reason we expect that is that the Secretary of the Federal Department of Health and Human Services sent out a letter to all of the state governors last year saying that they planned that the Secretary plans to provide 60 days notice before the agency allows the PHE to expire, or before if they were to revoke it sooner than the end of the 90-day period. So that 60-day notice would have been back in mid-May if the PHE were to end in July. So we were kind of waiting around mid-May. To my knowledge, I have not seen or heard of any notice from the Secretary. So that is signaling to us that in July, we are likely to see another renewal that would take us into October. So the commenter is exactly right. As of right now, it looks like that 151-day extension, if, and this is assuming if the PHE ends in October, it could be renewed again after that. But let's assume it was October, that 151 days would then take us into March of 2023. And then at that time, if nothing else happens, we would revert back to the regular Medicare telehealth rules, where a patient has to be in a rural geographic area at an eligible originating site. That's when we have to start thinking about whether this Consolidated Appropriations Act of 2021, also known as the rule that created the in-person visit requirement, may potentially kick in. But it wouldn't be until at least March of 2023 that we even have to think about this 6-month in-person visit requirement. Do we have any others in the chat, Molly? This would be a great time if there were any.
Not that I see. Thank you.
All right. Okay. So then we had, let me back up. One of the limitations of the Support Act is that it only allowed telehealth services to be provided to patients at home, ignoring all of our COVID flexibilities, to evaluate, diagnose, or treat substance use disorder or mental behavioral conditions co-occurring with substance use disorder. So what about all of the other mental behavioral conditions that may not co-occur with substance use disorder? Well, that's what the Consolidated Appropriations Act of 2021 did. It added on to our regular Medicare rules, provisions that also allow, right up here at the top of the pyramid, also allow telehealth to be rendered to patients at home for mental behavioral conditions via telehealth, and also allows certain of those services to be rendered as audio only on a permanent basis, even after that 151-day extension. When that happens, when we have to rely on the Consolidated Appropriations Act expanded access rules to be able to render telehealth for mental behavioral conditions to patients at home and via audio only, then the initial 6-month, the initial in-person visit requirement applies. So let me make clear again, though, right now during the public health emergency, because we can already render any Medicare telehealth service to a patient at home, the in-person visit does not apply. It will also not apply during the 151-day period after the public health emergency ends. Only after that 151-day period do we need to think about whether the 6-month in-person visit requirement applies. So let me talk about that in-person in-person visit requirement when it eventually could apply, no sooner than 151 days after the public health emergency ends. At that time, if we are rendering a service for a mental or behavioral condition that does not co-occur with substance use disorder, and the patient is at home, that's when we would have to have an in-person visit within 6 months of the first telehealth visit to a patient at home for the evaluation, diagnosis, or treatment of a mental or behavioral condition. It also requires periodic in-person visits after that. And the statute didn't dictate how often those periodic subsequent visits needed to be in person. So we had rulemaking through the agency last year that said, initially proposed every 6 months. Provider feedback and public comments said, no, that's too often. So Health and Human Services changed it to be every year that we have an in-person visit to be able to provide telehealth services for mental behavioral conditions that do not co-occur with substance use disorder to patients at home. And again, those subsequent in-person visit requirements do not apply, and they do not start until at least 151 days after the public health emergency ends. Even at that time, even at 151 days after the PHE ends, those subsequent visit requirements have some flexibility. That can be waived if, in the provider's professional judgment, the risks or the burden of an in-person visit outweigh the benefits. So if the patient's stable, if coming to the in-person visit increases the chances that the patient doesn't continue with their regular follow-up, or may, I don't know, not be able to fill a prescription, whatever the provider's professional judgment is, that subsequent in-person visit requirement could be waived. We just want to make sure the provider is documenting the reason why the burden or the risks outweigh the benefit of having that annual in-person visit. Unfortunately, where we don't have a lot of flexibility is that initial 6 month, that initial in-person visit within 6 months before the first telehealth visit for a patient with a mental behavioral condition, not co-occurring with substance use disorder, being provided to a patient at home. I want to also emphasize again, though, even if you are delivering a telehealth service for a patient with a mental or behavioral condition that does not co-occur with substance use disorder, if all regular telehealth requirements are met after that 151-day period, the patient's in a rural geographic area, they're presenting to an eligible originating site, all of those requirements, you do not have to have an in-person visit within 6 months of that first telehealth visit. That 6-month in-person visit requirement only applies if we have to rely on the Consolidated Appropriations Act expanded coverage because the service is being rendered to a patient at home rather than at an eligible originating site in a rural geographic area.
Rochelle, we do have a question in the chat. It's pretty detailed, so it might be easier if you wanted to read it.
Sure.
And it might be good to cover this because I do see a couple of our attendees are representing FQHCs, so it might be a good thing to talk about.
Sure, yeah, let me, no problem, Trudy. I'll read the question out loud to make sure I get the facts straight here. Are there specific codes on the CMS list of telehealth services that would or would not be appropriate for these mental telebehavioral health services? So, and Trudy, you are welcome to jump in and ask if you want to clarify that. But I think the short answer is yes, there are. So it depends on who the credentials and the licensure of the distant site professional. Because right now, during the public health emergency, we've also opened up who qualifies as distant site providers of telehealth services, FQHCs, RHCs, critical access hospitals, and any other professional who can enroll and bill and be paid under the Medicare program can act as a distant site professional right now during the PHE for the provision of telehealth. The day that the public health emergency ends, many of those professionals will no longer be eligible. So FQHCs, RHCs will continue to be eligible distant site providers for the 151-day extension, but a lot of professionals who are only able to bill telehealth during the PHE as a result of that flexibility that any Medicare enrolled provider can deliver telehealth, that will go away. So, and I'm trying to think of an example in the mental health context. If it's I don't remember off the top of my head, I apologize, if a psychologist or certain clinical social workers outside of the PHE are eligible distant site providers of telehealth. But let's say they're not, and they only are during the PHE as a result of that expansion. So within their scope of practice, they may be limited to what types of telehealth, what codes they can bill for services, telehealth or not. So that may be one restriction. But there aren't any codes on that telehealth list of approved telehealth services for Medicare that are specific to this Consolidated Appropriations Act coverage. So it could be an office visit code, a 99201 through 99215. It could be an inpatient H&P. It could be a subsequent hospital visit. It could be a skilled nursing facility visit. So that It really depends on the service that's being provided. I don't know if that answered your question or not, so please feel free to unmute and jump in if I can clarify any of that.
Yeah, so thank you. That does answer my question. And thank you so much for all the knowledge that you bring to these sessions. And I work with the Northwest Regional Telehealth Resource Center, and I took the CMS list of telehealth services and created a resource that kind of grouped them and had hyperlinks to MLN CMS resources as well. And we did one separately that was specific to telebehavioral health, which I just revised the other day because it was just too difficult to kind of keep current. But also for the, I keep thinking about, is there, number one, kind of a decision tree for when you need the in-person visit? So I'm kind of visualizing kind of a little process map for that. But for the second piece, and especially for the FQHCs that can now administer the newly defined mental health visits, creating a resource of the codes that they can use, because I haven't seen that. So if you have seen that, let us know where to find where the actual codes are that the FQHCs can use for the newly defined mental health visits. And I think that's all I wanted to add. I just feel like, we have the guidelines, but knowing what the specific codes are that we can all use, I think would be, I'd like to get that straight. I think that's really what I'm trying to say. So thank you for your patience with me.
Absolutely. And that's such a great point. I'm glad you brought that up. There was guidance recently from CMS, and it has come to us through questions through HTRC as well about this policy that FQHCs that certain mental health services qualify as an FQHC visit. And there was some question about whether that negates the 6-month in-person visit requirement. I think we've got a handout, Molly, that we can share. But what I'll do, Trudy, I jotted down your note about whether there are any codes that would have to be reported as part of that FQHC mental health visit that we can. I haven't seen a list either, but I'll take that as an action item for myself to research whether there are any specific codes. My takeaway from that, or my impression was, while FQHCs can provide mental health services as an FQHC visit, it doesn't negate the requirement to have an in-person visit within for the distant site professional that will be rendering these telehealth services 151 days after the PHE ends, at which time FQHCs and RHCs will no longer be eligible distant site providers of telehealth services unless a law passes between now and then. So they could be the originating site and have their originating site fee. This 6-month requirement really affects the distant site provider that would be rendering that service potentially to a patient coming to the FQHC or the RHC at that time. And it would not eliminate the need for them to have an in-person visit in that situation. Then I see the specific definition of rural geographic area. So Ashley, what I can do is send that out. It has to do with being outside of a metropolitan statistical area during the last census, but so I don't jumble that language up for you. I'll go pull that language from the Social Security Act. It's under, I think, section 1834M. If I remember correctly. And then there's even a map on HRSA's website that shows you where the metropolitan statistical areas are and are not. So you can take that definition, find your area, and figure out whether you are in what would be considered a rural geographic area for the regular Medicare telehealth rules. Which again, right now, during the public health emergency, we don't have that geographic area restriction, and we won't have it as a restriction for 151 days after the public health emergency ends.
And I will comment too for the everyone on today. I am taking notes of all of this, the comments and the questions as well, so that we can send something out with our follow-up materials. So you have those in hand also. So just keep that in mind. If we get short on time, I will be copying all of the questions and comments and making sure that we address them, and everybody who is on today gets that information.
And Molly won't let me forget. So we will get you answers. Okay, so I want to walk through a couple of examples. All right, and so I want you kind of in your head to think about what those regular Medicare billing requirements are, and that the 6-month in-person visit requirement only applies at minimum as early as 151 days after the PHE ends, and only to patients at home, and only if we're evaluating, diagnosing, or treating a mental or behavioral condition that doesn't co-occur with substance use disorder. And that just triggered, Trudy, you had a great comment about this decision tree. And this is sort of the way I visualize it, as almost like an inverted pyramid. But I think what that decision tree could look like is starting at the top. What are the regular Medicare requirements? And if those are all met, we automatically go to no, an in-person visit is not required. But if within those requirements, if the patient is not at one of those eligible originating sites, but instead, if the patient is at home, then our decision tree branches off. Does the patient have a substance use disorder? Yes or no? If the answer is yes, and that's part of what's being evaluated or treated, or a mental health condition co-occurring with substance use disorder, then the answer is no. Even 151 days after the PHE ends, that doesn't require an in-person visit. But if the patient's at home and has a substance use, does not have a substance use disorder, and we are evaluating or treating a mental or behavioral health condition not co-occurring with substance use disorder, and the patient's at home, then the answer is yes. That's when the 6-month in-person visit would apply, no sooner than 151 days after the public health emergency ends. So let's look at some examples here. Data service, we're going to go back in time. If anybody can remember prior to COVID, let's jump back in time prior to COVID. December 31st, 2019, I guess technically COVID may have been around then. That was before the public health emergency. We'll say that. Pre-COVID rules and pre-COVID flexibilities. We're rendering a telehealth service to a patient who has substance use disorder and is receiving treatment through this telehealth visit for anxiety and depression. The patient's located at an FQHC in rural Kansas. Does the 6-month in-person visit requirement apply? So in that case, it would not. The service would be covered as a regular telehealth service, okay? Prior to COVID, the patient's in a rural geographic area at an eligible originating site. I guess I'll assume that the CPT code being billed is a covered telehealth service by an eligible distant site professional. So it's a regular telehealth service. We don't have to rely on the substance use disorder law or the 6-month in-person visit requirement law to have that telehealth service covered. Right? Same time frame before COVID was here. We have our same patient who is receiving or who has a substance use disorder, and during this telehealth visit is receiving treatment for mental behavioral conditions that co-occur with substance use disorder. The patient's at home in rural Kansas. Does the 6-month does the requirement to have an in-person visit 6 months prior to this telehealth service apply? The answer is no, because that service to a patient at home, that's not covered under our regular Medicare telehealth rules, but it is covered under the Support Act. And the Support Act does not have the requirement that we have an in-person visit within 6 months of a telehealth visit to a patient at home for the treatment of substance use disorder or mental behavioral conditions that co-occur with substance use disorder. Okay, let's jump forward in time to the to our COVID PHE era, July 1st, 2022. So we're still in the COVID public health emergency. Okay, and a patient with substance use disorder is getting a telehealth service for the treatment of anxiety, depression, conditions that co-occur with substance use disorder. The patient's at an FQHC in rural Kansas. No, the 6-month in-person visit requirement does not apply because during the public health emergency, this visit would be covered as a, well, I guess during or outside of the COVID public health emergency, this would be covered as a regular telehealth service. We're in a rural geographic area, and FQHC is an eligible originating site. We'll assume that the service is the CPT code for the distant site professional is on the list of covered telehealth services and rendered by an eligible distant site professional. We don't have any need to rely on the Support Act, the Substance Use Disorder Act, or the 6-month in-person visit, the Consolidated Appropriations Act of 2021 coverage. That's just a regular telehealth service. So let's take this patient, July 1st of 22, with all of our COVID flexibilities. Patient has substance use disorder, is receiving treatment via telehealth for conditions that co-occur with substance use disorder. And the patient is at home in rural Kansas. The 6-month in-person visit still doesn't apply because during the public health emergency, we can render any telehealth service to a patient at home as a regular Medicare telehealth service. We don't have to rely on the expanded access and flexibilities through the Support Act or through the Consolidated Appropriations Act of 2021. Okay, July of 22, we're in the middle of the COVID PHE, and now we've got a patient without substance use disorder, receiving evaluation, diagnosis, or treatment via telehealth for mental or behavioral health conditions that do not co-occur with substance use disorder. So the fact that they don't co-occur with substance use disorder wipes out the Support Act. To be able to render this telehealth service, it has to either be able to be covered as a regular Medicare telehealth service or be available through the Consolidated Appropriations Act, where the 6-month visit requirement, in-person visit requirement applies. During the PHE, this patient is at home in rural Kansas, but we still do not have to have an in-person visit because during the public health emergency, we can provide any telehealth service to a patient at home. It doesn't matter whether the diagnoses are mental or behavioral health conditions, whether they do or do not co-occur with substance use disorder. So I'm going to pause there because I see a comment in the chat. What qualifies for a 6-month service? Can it be done by someone in the group? And that's a great question that came up during the rulemaking in 2021 for this year. When we're looking at the way the statute was written is that in-person visit that has to occur within 6 months of the first telehealth visit for mental behavioral conditions to a patient at home. The statute says the provider has to render that in-person visit. So Medicare said, gosh, it says the provider. Does that mean the exact same individual who will be delivering the telehealth service has to provide the in-person visit? And Medicare considered that under Medicare rules, providers of the same specialty in the same group practice bill and are paid as if they are a single individual. And so in the rulemaking that came out last year, Medicare said they would allow other providers of the same specialty in the same group practice to have the in-person visit within 6 months of the first telehealth visit for mental behavioral conditions to a patient at home once that in-person visit requirement applies. So let's stay within our COVID time frame. A patient being seen via telehealth for anxiety or depression. Is this the same scenario covered as a regular telehealth service? So let's jump ahead to this scenario. We're still during COVID. A patient receiving a telehealth service via audio-only telecommunications technology for mental or behavioral conditions that do not co-occur with substance use disorder. Patients at home in rural Kansas. The in-person visit requirement does not apply because during the public health emergency, we can provide any telehealth service to a patient at home. And many telehealth services can also be rendered as audio only during the public health emergency and covered as regular telehealth services. So the in-person visit requirement doesn't apply. I see another question in the chat. Can a nurse practitioner and a physician assistant and a psychiatrist all be considered to be in the same specialty? And I think that's a great question because I've had this come up before where we've got providers that all act as behavioral health providers in a group practice. But when they enroll with Medicare on their 855I Medicare enrollment form, their specialty designation for nurse practitioners and PAs, there's a special nurse practitioner taxonomy code. It's like I want to say a 50 for nurse practitioners. They can designate behavioral health or I don't know the exact name of the specialty as a secondary specialty. So there was kind of a question of whether that designation using code 50 as their specialty when they enroll as a nurse practitioner causes them to be in a different specialty than the psychiatrist, whose primary specialty on the Medicare enrollment is going to be psychiatry or mental behavioral health. The way I've seen that practically apply is that the nurse practitioner and PA, even though they've got a different specialty designation as their primary specialty on the Medicare enrollment, when they are acting as the behavioral health provider in that same group practice, in that same tax ID as the psychiatrist that they're working with, that mental behavioral specialty is imputed on the nurse practitioners and the physician assistants. So that's a great question. So let's assume that the PHE did end in July. And again, I don't expect it to, because I think we would have gotten our 60 days notice, but this is just kind of for illustration purposes. If the PHE ended in July 15th, and we have a patient that we're seeing via telehealth, August 1st of this year, for mental or behavioral conditions that do not co-occur with substance use disorder, for a patient at home as an audio-only service. The 6-month in-person visit requirements still do not apply because of the 151-day extension after the public health emergency ends, making all regular telehealth services available to patients at home, and those that are eligible for audio only can still be rendered as audio only for 151 days. That service will be continued to Let me say that again. That service will continue to be covered as a regular Medicare telehealth service without requiring that we rely on the Consolidated Appropriations Act of 2021. So now let's jump ahead. If the PHE were to end in July of this year, August of next year would be outside of that 151-day extension. Let's also assume that nothing else happens in terms of an act of Congress to change the normal Medicare billing rules between now and then. So at that time, after the 151-day extension, when the PHE ends, is gone, when we provide a telehealth service to an individual for mental behavioral health conditions that do not co-occur with substance use disorder for a patient at home, then the 6-month in-person visit requirement applies. Same thing, that same service is provided August of next year. Patient is receiving treatment for mental behavioral conditions that do not co-occur with substance use disorder, but the patient is at an eligible originating site in a rural geographic area. Even if that telehealth service is rendered as audio only, the in-person visit requirement doesn't apply, because under that rule, as long as the patient is at an eligible originating site, we can't, excuse me, I said audio only, audio-visual technology, that would be considered a regular telehealth service. And we do not have to rely on the Consolidated Appropriations Act to cover that service. So we don't need an in-person visit within 6 months. Okay, same service. Sorry, I already revealed the answer here. For a patient with substance use disorder, receiving treatment for mental behavioral conditions that co-occur with substance use disorder. After the 151-day extension ends, we do not need an in-person visit for that service, because if the patient is at an FQHC in a rural geographic area, and I think as someone mentioned in the comments, healthcare provider shortage area, then it's covered as a regular Medicare telehealth service, no in-person visit requirement. Same patient, same day, after the 151-day extension ends, with substance use disorder, being seen via telehealth for a mental or behavioral condition co-occurring with substance use disorder at home. This patient does not need an in-person visit within 6 months of that service, because that visit is covered under the Support Act. And the Support Act, for some reason, does not have the same in-person visit requirement as the Consolidated Appropriations Act, where the patient doesn't have a co-occurring substance use disorder. So I know that's a lot of details, and Trudy, I think you're right on point that it's really a decision tree, a mental exercise to get down to whether that requirement applies and when. But hopefully that gives you some examples of how we would consider whether that requirement applies once the 151-day extension after the PHE ends and we have a telehealth visit for mental behavioral condition not co-occurring with substance use disorder for a patient at home might apply.
As I said, we would have a lot to cover, and I knew it would initiate questions. As I said earlier, I did document all the questions that came through. Also, we had some great resources and links shared by Trudy and Tony, so I have documented those as well. I think for the greater good, we will pull it together and just take a quick review and organize them a little bit so that it's clear as it relates to the presentation that Rochelle provided today. So keep your eyes open for that. May take us a little bit longer to get the follow-up email because of the content and the amount of resources we're going to share. So just keep your eyes open, and we'll get that out to you. As always, you can email us at htrc@kumc.edu. And I'm going to copy that last question that's in here. If you need to hop off, please do.
Yeah, and I can answer it too, Molly. I saw
Okay.
that one pop up, that it
That's
cannot
fine.
be after, it has to be before. The question was, can that 6-month in-person visit be after the first telehealth service? And it's got to be before. What I don't know, well, what our guidance is right now, that if the 150-day extension were to end now, whether patients who were already in your system and already established patients, whether they would have to have an in-person visit to begin or continue really the services that they've been receiving for the last 2 years. The guidance that I got from Medicare was that they would. I plan to keep an eye on that in the Medicare physician fee schedule coming out, the proposed rule coming out this July. I plan to submit that question for clarification. So we may have different guidance coming out formally from Medicare later this fall.
Thank you. And also keep your eyes open. We will be sending out the information for our June 29th webinar. And then we will also possibly be hosting one the end of July related to the PHE flexibility. So Rochelle can update on that as well. Thank you so much, everybody. Have a great rest of your week, and we'll be in touch.